my name is Stacy Hunter. I'm a second year here at Lincoln Memorial University DeBusk College of Osteopathic Medicine. So anatomy can be pretty scary. I know that. But it can be really cool too, because you get to figure out, okay, what muscles do what is the action of them, what's the innervation, like what nerve goes to it, what's the blood supply. And all of that can tell you a whole lot about the body and about how you work. So today we're going to talk about the upper limb as well as the back. Now on my PowerPoint, I've got in the notes section some important resources that you can use that either clarifies things more, it has different pictures and different ways of learning, or there's some also practice questions. Now, of course, if you have any questions, please email me anytime. Let's get started. So our spine is composed of vertebrae. We've got cervical, thorax, we've got our lumbar, and then we have our sacrum and coccyx. That makes up our vertebrae. We've got different types of curves. We've got lordotic and kyphotic. Now, lordotic is more of a backwards curve. That would be in our neck, which is our cervical region, as well as in our lower back, our lumbar. Kyphotic is more of a forward curve, and that's in our thorax and our sacrum. So how can I remember that? So lordotic starts with L. Cervical and lumbar both have an L in them. Thorax and sacrum do not. So that's perfect. I can remember that. Cervical and lumbar, both with an L, so that's lordotic curves. Now, throughout my PowerPoint, you'll see that I've highlighted certain things. Either it's of clinical importance, or I just find that it's high yield to know. So, kyphotic in my thorax and sacrum. Excessive kyphosis is usually due to osteoporosis, wedge fractures, and that's found mostly in elderly women. Now, my thorax, lumbar, and cervical region, as well as my sacrum, they make up my vertebrae. There's 7 cervical, 12 thorax, 5 lumbar, and also 5 sacral vertebrae. So how I can remember this is breakfast at 7, lunch at noon, and dinner at 5. So 7 cervical, 12 thorax, and 5 for lumbar. And the ribs, they articulate with the thoracic vertebrae via facets. So a typical vertebrae is shown here on the left. So we've got spinous processes, and that's, if you feel your back, you can feel all of the knots that go down your spine. That's our spinous processes. If you go over to the left and the right, you can feel, if you push deeper, sometimes you feel something that's hard. That's our transverse processes. And that's very important in osteopathic medicine. And you'll learn more about that this semester, about using muscle energy or HVLA. In the middle of our vertebrae, we've got our vertebral foramen. And in that foramen sits our spinal cord. Foramen just means opening, and you'll find many foramens in the body as we move along. So we've got facets, and the facets are things that articulate. So these are going to articulate with other vertebrae. And then the body is more anterior to our spinous processes. So if there's a violent hyperextension of our spine, there's going to be an injury to the pedicle as well as the spine. So let's talk about where the pedicle is. The pedicle is right here between the body and the transverse processes. So pedicle, that means feet. So I sort of think of these as feet coming right off the body, pushing on these transverse processes. So it makes sense that the pedicle might be hurt with a violent hyperextension. So the thoracic vertebrae, there the bodies are more of a heart shape. The lumbar, they're larger. The bodies are more kidney shaped. There's also some unique vertebrae. So in our cervical vertebrae, 3 through 7, they've got these bifid spinous processes. So what's bifid mean? It means two. So like we can see on the right, there's just one spinous process, but here it splits into two in C3 through 7. It also has this transverse foramen for our vertebral artery. So what is our vertebral artery? Well, don't worry about that yet. Just know that it travels here. So where it actually travels is it goes up into our brain to give our brain blood. This only goes up from C6 up to C1. It does not happen at C7. That's important to know. The cervical vertebrae, the facets are horizontally oriented and tightly intertwined, and they more easily dislocate than they do fracture. C1 and C2 are very unique, and they're special, so they have special names. So there's atlas, which is C1, and axis, which is C2. So on a test, they could either say C1 or C2, or they could put atlas or axis, but they're not going to put both like I've written it. They're not going to put atlas C1. You have to know those terms. So how's it different? So the atlas, as we can see up here on the right, it has no spinous process and no body. So it's very different from the rest. C2, my axis, it has a spinous process and has a body. But there's this part called the dens, and it comes up and articulates with the anterior arch of my atlas, and that's called my atlantoaxial joint. That is held together by my transverse ligament of the atlas. If there's laxity, that can cause subluxation of C1 onto C2, and that can cause quadriplegia. So, why is this important? Well, sometimes we have to get cervical x-rays. So, people with rheumatoid arthritis or people with Down syndrome, they actually have to get x-rays of their cervical spine before they're allowed to play sports, because if there's laxity, they could have major trauma and they somehow get hit. This could definitely impact their life and could result potentially in death. So this alar ligament attaches from the dens to the occipital bone. The occipital bone is on the back of your head, and this is at the atlanto-occipital joint. Rupture increases contralateral movement. So contralateral, contra meaning opposite, lateral, moving to the side. So if it ruptures on the right, your head would move to the left. Sacrum and coccyx. So our sacrum looks very different in our coccyx than the rest of our spine because it's fused. The sacral hiatus is missing lamina from L4 or L5, and this articulates with the pelvis. We have joints and disc. So our zygapophyseal joints are between our superior and inferior articular processes, which are synovial joints. Now, many of you have probably heard of herniations. So the most common disc herniation is posterior lateral. So it's posterior, so back, and lateral to the side. So it's sort of at what one of the students from boot camp called it, sort of southeast or southwest. And this is due to a thinner part of the annulus fibrosus, and there's no ligament support. So the annulus fibrosus is around this nucleus pulposus. So I sort of think of that as like a jelly donut. So the jelly is my nucleus pulposus, and the donut part is the annulus fibrosus. So if there's a thinner part, it can protrude and that nucleus pulposus might come out. Okay, we've got ligaments of the spine, and I color-coded it so it would match our picture. So we've got a supraspinous ligament. So supra above, spinous, like our spinous processes. It's going to limit flexion, which makes sense. If I move forward, those above the spinous processes, it's going to stop me. In the cervical spine, it's called a nuchal ligament. The posterior longitudinal ligament, my PLL, it's also going to limit flexion. If I flex forward, it's going to be tighter. While my anterior ligament, if I'm flexing, it's going to scrunch up and get closer together. But if I bend backwards and extend, that anterior longitudinal ligament is going to prevent extension. So, in a whiplash injury, the spinal cord can be severed, and that's due to that hyperextension. My discontinuous ligaments, so they're not all the way down like the ALL and PLL, are my ligamentum flavum between my lamina and my interspinous ligaments between the spines. Blood supply to my vertebrae. Okay, we've got arterial and venous. So my spinal branch is in the intervertebral foramen. It supplies the bones, ligaments, and the meninges. My radicular or segmental medullary supplies the roots and the spinal cords. So here is my radicular segmental medullary, right there. And here's my spinal branch. And in my intervertebral foramen right there. The venous supply. So veins drain and arteries are pumping blood from the heart. So my intervertebral vein travels with the spinal branch artery. So like right here, here's the artery. There's going to be a vein traveling with it, and that's that intervertebral vein traveling in the intervertebral foramen. That's an easier name. It tells you exactly where it's traveling. The basovertebral vein drains the bone marrow. And here's that one in the picture. It's in the body. Okay, let's talk about back muscles. Our extrinsic back muscles move the upper limbs and ribs. They are innervated by the anterior or ventral rami. Don't worry about having to know what levels they are. Just know that it's anterior rami. So the superficial muscles are trapezius, latissimus dorsi, rhomboids major and minor, and levator scapulae. The intermediate muscles are serratus posterior, superior, and inferior. So don't worry, we're going to go through all of these. Here's my traps. So don't worry as much about the attachments, but it's important to know where it's located generally. So we're going to start at the occipital bone and nuchal ligament. Remember, we had talked about that ligament, as well as the spinous processes, the spine of the scapula, acromion process, and the lateral third of the clavicle. This one is innervated different. It's not just anterior rami like we said. This one is cranial nerve 11, which is our spinal accessory nerve. That's very important to remember since it's different. The blood supply is the superficial branch of the transverse cervical artery. So try to remember transverse cervical. As you can see in the picture, it has 3 bodies to it. The superior, which is descending, because it's descending fibers, it's going to elevate the scapula or shrug the shoulders. So if you shrug your shoulders, that's due to the trapezius. The middle adducts or retracts the scapula. The inferior or ascending depresses the scapula from an elevated position. So if I shrug my shoulders and then I push my scapula down, then that is what the inferior is ascending to. Superior and inferior together rotate the scapula upwards, and that is called muscle synergy. So that's very important to remember that these are synergistic. So what does synergy mean? It just means that these two working together achieves a greater purpose, and that would be rotating the scapula upwards. So if we have an injury to this cranial nerve 11, we're going to have ipsilateral, meaning same side, shoulder drop. Latissimus dorsi. So it's going to attach to the intertubular groove of the humerus. Now, what's important about this? It's a back muscle, but it's attaching to the arm. So it's just really important to remember that even though it's on the back, it's attaching to my arm. So you don't have to remember what groove it is, but it's important to remember that it's attaching to the humerus. It also attaches to the lower 3 ribs, iliac crest, thoracolumbar fascia, sacrum, and T7 spinous process. It's innervated by the thoracodorsal nerve, and the blood supply is the thoracodorsal artery. When we get to the brachial plexus, we'll talk more about that nerve. So the actions are going to all involve the arm since it's attached to the arm. So we're going to adduct the arm. So when we adduct, we bring things together. So we bring our arms in, extend the humerus, so push it back, and internally rotate. So if I take my shoulder and I move it toward me, so it's like medially rotating, versus if I bring my shoulders together, that's medial. If I bring them apart with my arm going out, then that would be externally rotating. So muscles with the same action, adduction of humerus, extension of humerus, and internal rotation of humerus, are pec major, teres major, and then as well as our latissimus dorsi that we're talking about. So the way I can remember this is 2 majors and a miss. So we have pec major, teres major, and the mus or miss is latissimus dorsi. Levator scapula and rhomboids. So here's my levator scapula right here, and here's my rhomboids. So here is my scapula, and so if these contract, they're going to get closer together from the origin to the insertion. So my levator is going to pull up, so that's going to elevate my scapula. With my rhomboids, if they contract, they're going to adduct and retract my scapula. So if I'm looking in lab and they, let's say, tagged one of these, I'm like, I don't know which is which, major or minor. Most of the time, it's minor over major. So remember that in your head. So this is rhomboid minor, and this big muscle is rhomboid major. The innervation for these is the dorsal scapular nerve, and the blood supply is the dorsal scapular artery, or the deep branch of the transverse cervical artery. Remember, we had talked about that transverse cervical artery when we talked about the traps. Okay, serratus, posterior, superior, and inferior. The innervation is the anterior rami. And the action is proprioception. So what's that mean? It just means that you know where you are in space and you elevate and it depresses the ribs. Okay, the intrinsic back muscles. So these are our true back muscles. It's what we think about when we talk about our back muscles. So that supports and it moves our vertebrae to maintain posture. So our innervation is slightly different. It's our posterior dorsal rami. So they're deep muscles. So deep to deepest, we're going to go spinous transversalis, then deeper, erector spinae, then deeper, transversospinalis, and then our intrinsics. So let's start with spinotransversalis. So we've got splenius, capitis, and cervicis. So I think of like putting a splint on somebody's arm. Let's say they broke their arm. If you put a splint on it, it's going to be over their arm. So the splenius capitis is going to be on top of the other deep muscles. It's going to attach at that nuchal ligament that we talked about, our spinous processes, transverse processes, and our mastoid process. Bilaterally, it's extending our head and neck, and then unilaterally rotating that neck to that same side. Okay, erector spinae. This is our I love spinach muscles. So I is iliocostalis, love, longissimus, and spinach, spinalis. So spinalis, I think of, okay, that sounds just like spine, and that's where it is. It's more medial. And then our iliocostalis is more lateral. So it's good to remember, this is not just on one side. This is our patient's right side, but it's also going to be on our left. So they maintain posture. They bilaterally extend the spine and unilaterally flex the spine to the same side when that person is upright. Iliocostalis and longissimus come inferiorly as a broad tendon. And you can sort of see that here at the bottom. Transversospinalis. So how I remember these muscles is rip my shirt. So that's rotatorius, multifidus, and semispinalis. So semispinalis is semi on the skull, semi on the spine. There's semispinalis capitis. So a cap would be over, it would be on my head, and then that would be on top of my neck, so cervicis. And we also have semispinalis thoracis. Multifidus, which is largest in the lumbar region and probably where you're going to see that in lab, that's important for posture. So the action of these muscles is to maintain our posture, proprioception, bilaterally extend the spine and the head, and unilaterally rotate the head and spine contralaterally. The suboccipital triangle. So that is in our neck. So the borders are rectus capitis posterior major, obliquus capitis inferior, and obliquus capitis superior. And you can see these. Now, the one that's not in our triangle is rectus capitis posterior minor. It's over here. The two attachment sites, usually attachment sites aren't too important, but these are. This would be the transverse process of C1, and that is where obliquus capitis superior and obliquus capitis inferior meet. And then the other corner of our triangle, which is our spinous process of C2, and that is where rectus capitis posterior major and obliquus capitis inferior from our suboccipital triangle meet, and also rectus capitis posterior minor also meets there. Our nerves, C1 is suboccipital motor, and then C2 is our greater occipital, and that's going to be sensory. Our blood supply is our vertebral artery and our occipital artery. And these bilaterally extend the head, and then unilaterally, it's going to rotate that head to the same side. Our nervous system is very important. So our somatic deals more with our external environment. Our visceral is more of our internal. So in osteopathic medicine, you'll hear a lot about somatic dysfunctions. And then the visceral, I think of more as like organ systems and what's like in the body. So the spinal roots are motor or sensory, but they're not mixed. They're not both of those. But our spinal nerves, like on our anterior or posterior rami, they are mixed. They can be both. Our spinal nerves exit at the intervertebral foramen near that zygapophyseal joint. Now our posterior roots, our dorsal roots, they're going to be sensory only, where our anterior roots, ventral, they're going to be motor only. So how I remember these are SAD, VEM. Sensory, afferent, and dorsal horn. And then on the ventral side, it's ventral and it's efferent and motor. And so afferent is meaning that it goes to the spinal cord. Efferent, I think of like, starts with an E, like exit starts with an E. So that's coming from my spinal cord. So just remember, so here's my roots. So you can see it's either red or blue, but not both at the same time. So that's going to be motor or sensory. So here's my sensory at my dorsal horn coming from there. Here's ventral, that's going to be motor only. And then as they come together at the spinal nerve, they're mixed. We've got red and blue going to our rami. Okay, so our vertebral canal and meninges. We talked a little bit about the vertebral canal. So the contents, it's got a lot of stuff in there. It's got our spinal cord, the meninges, our epidural fat, venous plexus, arteries, and nerves. So this picture at the bottom does a really good job of showing what's in here. So our meninges and spaces, we're going to go lateral to medial. So we first have our epidural space, and that space is where we give women injections in order to, right before they're having a baby, we give that block so that they don't feel it, our epidural. They're like, I want an epidural. Well, this is where it is at. It's our epidural space, right outside our dura mater. If we hit that dura mater, it makes a popping noise, that means we've gone too far. Right, so our dura mater, that means tough mother. It's really tough. That's why it makes a popping noise when they go through. We've got our subdural space. Then we've got our arachnoid mater. And then we have our subarachnoid space. Then we have our pia mater, which is touching the spinal cord, right on top of there. So arachnoid, that means spider. And I sort of think of these ventral rootlets that are in here, sort of like spiders in my subarachnoid space. So it's important to know what's a true space and what is a potential space. So what in the world does that mean? True space means that there can actually be fluid in there. They're supposed to be fluid. So for example, our subarachnoid space contains cerebral spinal fluid, CSF. So if we need to do a lumbar puncture because we think the patient has meningitis, for instance, then we have to go through our dura mater and our arachnoid mater in order to get into there, to get our lumbar puncture. And then we have to pull the needle back out. Our subdural space, that is potential space. So if fluid fills in there or blood, that's really bad because there's not really any space. As you can see, the dura mater and arachnoid mater are really close together. Okay, we talked a little bit about herniations, and now we've got to figure out, okay, if a nerve is affected, like what's going to happen next. So in our neck, our nerves are coming out. And this was like one of the things that was really hard for me to understand for some reason. But our nerves come out and they go over the vertebrae that they're numbered by. So for example, C6. So between C5 and C6, C6 nerve is coming in on top of our C6 vertebrae. Then we go down, we've got C7, and that's going to be above our C7 vertebrae. Okay, now we have C8. We don't have 8 vertebrae, but that's okay. We've got an 8th nerve. So that C8 is like our mismatch, and it's coming under C7 and over T1. And since we've added a nerve in here, now it's going to mess up our system of naming. So now under T1, now we're going under. So after C7, before our nerve comes over the vertebrae, but now after that, we've got that C8 introduced. So under T1, we're going to have T1 spinal nerve. So here we are down here in the lumbar spine. It's still continuing that way. So L4, we've got L4 spinal nerve under it. Here's our L5. L5's under it. So what does this mean? If I have a posterolateral herniation, which would be like right here, it's pushing back and a little bit laterally. L5 is going to be affected. If it's very lateral, then L4 would be affected. But remember, posterolateral is the most common, so L4, L5, this disc space. If it's posterolateral, it's going to be the bottom one that's affected. If it is a just pure lateral herniation, since that nerve root comes under the vertebrae, L4 gets affected. If you do not understand this, please watch some YouTube videos, please email me, please ask a professor. This keeps coming back over and over and over again. It's going to come back up in EPC, it's going to come back up in OPP, it's going to come back up next year. So just make sure you understand this, okay? And do some practice questions, and that'll sort of see if you understand it. Okay, conus medullaris and cauda equina. So our conus medullaris, so like our actual spinal cord, what we think of, it comes to a cone shape, and that's going to end at L1, L2. Our cauda equina, so our horse's tail, so after that, we've got like lots of like nerves coming off of this, and that's called our cauda equina. And that begins after the termination of our spinal cord. So why does our spinal cord end earlier than our spine? So when we're developing, it's actually all the way down there. But as we grow, our vertebrae get bigger, we get taller, but our spinal cord doesn't. And so it ascends up, and it ends up ending at L1, L2. Our dentate ligaments, denticulate ligaments, they are lateral extensions of the pia mater that help anchor it in place. The lumbar cistern is the continuation of that subarachnoid space that we were talking about from L2 to S2. So why is this important? So we don't want to hit our spinal cord when we do a lumbar puncture, like we had talked about. So you need to do a spinal tap anywhere from L3 to L5. Since it's ended at L1, L2, and every person is different, there's some differentiations, I would probably hit for L4, L5 to make sure that you don't hit that spinal cord. Okay, so we're done with the back, and now we're going to move to our upper extremity. So here's our shoulder. So sternoclavicular joint, we've got our acromioclavicular joint and our glenohumeral joint for our joints of the shoulder. Now, joints are named, and ligaments typically are named after where they are and where they're going to. So sternoclavicular, we have our sternum and our clavicle. So it's going from our manubrium to our clavicle. Easy. So there's 3 ligaments. Our interclavicular ligament, so that's between our clavicles. We've got our sternoclavicular ligament, so sternum to clavicle, and then costoclavicular ligament. Costo meaning rib, and to my clavicle, from first rib to clavicle. Okay, my acromioclavicular joint, acromion to clavicle, it's going to help with rotation and gliding. And here's the ligaments right here. And then our glenohumeral joint is what we think of as our shoulder joint. This is really important to know. So this is our steroid injections of our subacromial space. It's our tissue layer. So it's important to know, and these are numbered, what you're hitting as you go down. So here's 2 ways, here's a needle, here's 2 ways that you can introduce this injection. And we want to get this injection into the joint cavity itself. So either we go through the acromion or our coracoacromial ligament. We wouldn't want to go through the acromion itself, but that ligament. The subacromial bursa, the supraspinous tendon, the glenohumeral joint capsule, and then the glenohumeral joint cavity. Okay, blood supply to the shoulder. We've got arteries and we have veins. So our arteries are our suprascapular, subscapular, anterior and posterior circumflex humeral, and our circumflex scapular arteries, which make the anastomosis. So what in the world does that mean? So circumflex means around. So circumflex scapular, it's coming from my scapula. Anterior and posterior circumflex humeral, they're going to come from the back and the front around my humerus. Suprascapular, that's coming from my back, it's coming around to the top, and subscapular is coming again from my back, from around where subscapularis is, to anastomose to supply my humerus. My veins. So we have cephalic, and that's going to drain into my axillary, and that's going to drain into the subclavian vein. And we're going to talk more about the blood supply of the arm itself. But let's talk about the muscles first. Okay, so we've got axioappendicular, and we've got scapulohumeral shoulder muscles. I just put these up here so you could actually see what they are. It's not necessarily important to know what category that they go into, except probably knowing that the rotator cuff muscles are supraspinatus, infraspinatus, teres minor, and subscapularis. Okay, let's start with serratus anterior. It's innervated by my long thoracic nerve. We'll talk about that when we talk about the brachial plexus. If we have an injury to that, that will be the winged scapula. So the scapula looks like a wing, it's higher than the other. my blood supply is going to be my superior and lateral thoracic artery. Lateral thoracic is the more important one to remember. So it's important to look at this lateral thoracic artery, but it's the long thoracic nerve. So don't get those two confused because it's very similar wording. So the action is that it's going to laterally rotate and protract that scapula. So it's like punching forward. And then abduct it. So I think of abducting like if I'm getting abducted into space, so I'm like moving my arms up. And that's past 100 degrees. We're going to talk about all of the abductors, but it's important to know that that's my last part of my abduction. Okay, so we've got pectoralis major and minor. And our pec major actually goes over our pec minor. So usually I said it's minor over major, but in this case it's different. Our pec major is a really big muscle and it's innervated by two nerves, lateral and medial pec nerves. Our pec minor is innervated by our medial pectoral nerve. So in lab, this is really important because if I'm looking and I'm like, okay, I don't know what I'm looking at. I just see arteries and nerves and I don't know which one's which. Just don't panic. Think about it. The medial pectoral nerve pierces my pec minor and it goes to my pec major. So if I see a nerve going through that pec minor, I know that that's got to be my medial pectoral nerve. And that's sort of hard to remember. Okay, is it medial or lateral that pierces it? But if you look at it, the pec minor is more medial than pec major. And so that lateral pectoral nerve just goes straight to pec major. The blood supply for both of these is the pectoral branch of the thoracoacromial trunk. So the actions of pec major are flexion, adduction, and internal rotation of the arm. So I sort of think of a bodybuilder. And so they flex their arms and they bring them together, adduct it, and then internally rotate it because they're trying to look great for the competitions. So anyways, that's how I remember the actions for pec major. Pec minor, it's actually attached to the scapula, so it's going to stabilize that scapula by drawing it inferiorly and anteriorly against the thoracic wall, keeping that in place. So let's say I get a stab wound. I get stabbed more superior and lateral. So I'm thinking, okay, it's lateral, superior. That's going to affect my lateral pectoral nerve. So I'm not affecting pec minor. So what actions do I do? I'm going to have a weakened adduction and internal rotation of the arm. There's a bunch of muscles that flex my arm, so I'm good. Okay, subclavius. That's a little muscle that sits under my clavicle like submarine, under the water. Clavius is my clavicle, so my subclavius sitting under that clavicle is innervated by nerve to subclavius. Super easy name. The blood supply is the clavicular branch of the thoracoacromial trunk, and it acts by anchoring and depressing the clavicle. It's not very high yield. It's pretty low yield. Deltoid. This one is an important muscle. This is where people get IM injections. So like the flu shot, for instance, that goes in our shoulder. Well, it's actually going in the deltoid muscle. So this is innervated by the axillary nerve. That's coming off of the posterior cord. So if you're confused, just don't worry. We're getting to the brachial plexus. And so you can understand that more, like what the cords come from and where the nerves are traveling from that. So the blood supply is the deltoid branch of that thoracoacromial artery, as well as anterior and posterior humeral circumflex artery, but thoracoacromial is the most important. So the action is going to be flex and internally rotate the humerus. It's also going to extend and laterally rotate the arm as well, because it's got like different heads. So it's got a anterior, posterior, and middle head. And it's going to also abduct the arm 15 to 100 degrees. So we're going to learn all of the abductors of the arm. So now we've learned 2. So we'll add a third one on. But it's really important to know what abducts the arm. And this is the majority of the abduction, is the deltoid. Teres major, it's not as high yield either, but it's innervated by the lower subscapular nerve. Its blood supply is the subscapular and circumflex scapular arteries, and it internally rotates and adducts the arm. So it's attaching to the front of the arm. So if it's attaching to the front, I sort of think about where it attaches, and it's coming from my back, so it's going to pull that humerus around and rotate that inward, as well as pull it to my body. Rotator cuff muscles are super, super important, so make sure you know these. The other name for them are our sits muscles. So supraspinatus, infraspinatus, teres minor, and subscapularis are the sits muscles. So as you can tell, our SIT, supraspinatus, infraspinatus, and teres minor are all attaching on the front to the greater, or on the back to the greater tubercle of the humerus. So they're coming from the back, they're attaching more posterior, so they're going to externally rotate my arm. Subscapularis, it's sitting on the more anterior portion of my scapula. It's still on my back though, and it is coming around and attaching to the lesser tubercle, which is more anterior. So it's going to pull that toward my back, and it's going to internally rotate my arm. So I've got a nice chart to look at the innervation and blood supply. So supraspinatus, it gets the suprascapular nerve and artery. And you can see that it's here at the top, above the spine of the scapula. Okay, infraspinatus, that's going to also get the suprascapular nerve and suprascapular artery. So we just repeat the same innervation and blood supply. And that's under that spine of the scapula. Okay, teres minor is where it changes. We've got our axillary nerve, and remember that's what the deltoid was also innervated by. And the blood supply is going to be the posterior circumflex humeral and the circumflex scapular artery. So that one's a little bit harder, but it's on the back. It's going around to my humerus, so posterior circumflex. And then it's at the scapula, so circumflex scapular artery. Okay, and then subscapularis is pretty easy, subscapular nerve and artery. So, Army over Navy is something important to remember. And so suprascapular artery runs over the suprascapular ligament, and then the nerve runs underneath. Okay, these spaces are very important, as well as the interval. So we've got quadrangular space, triangular space, and triangular interval. And I've got these color coded just like on the picture, so you can pick them out. So our quadrangular space, the borders are our teres minor, teres major, humerus, and the long head of the triceps. And as you can see with teres, major and minor, there's going to be minor over major. It's following our pattern. In that quadrangular space, our axillary nerve comes out and our posterior circumflex artery. In our triangular space, we've got our circumflex scapular artery, and the borders are going to be teres minor, teres major, and the long head of the triceps. Our triangular interval is going to have our radial nerve and the deep brachial artery. The borders are going to be the teres minor, lateral head of the triceps, and the long head of the triceps. And this is going to supply and innervate my posterior arm. And it's more posterior. It's further down, more distal, and more posterior. So it makes sense that the radial nerve and deep brachial artery are coming out. The quadrangular space is more in my armpit region, so that would be my axilla. So I think, okay, axillary nerve, that makes sense. Okay, breast tissue. So this is innervated by my thoracic intercostal nerve and supraclavicular nerve. The blood supply is the internal thoracic artery and lateral thoracic. So this is super important that you know the path of the lymph nodes. Now, people might tell you, oh, it's okay, like you can cut the lymph out, which is true, but make sure that you know the order of the lymph nodes. Now, not every lymph node in your body is important, of course, but this is important. So if they ask you a question on something like, this patient has cancer, and the doctor is concerned about cancer traveling, you need to know if they give you, they took a biopsy of the central lymph node, and where would it travel next? So you need to know the order that they travel. So humeral, scapular, and pectoral go to central, which then go to apical, to supraclavicular, and then subclavicular. So make sure you know that path. Okay, so the axilla. You need to know the borders of the axilla, so that's our armpit. So our inlet is the axillary artery and vein, as well as our brachial plexus roots. The floor would be our skin, our clavicipectoral fascia, and the intravestibular nerve. The contents are going to be our medial, lateral, and posterior cords of the brachial plexus, axillary artery and vein, biceps brachii, and coracobrachialis. So I would really know the contents as well as the walls, the medial, lateral, anterior, posterior wall. So that medial border is going to be our serratus anterior and our thoracic wall. Lateral is going to be that intertubercle groove. My anterior portion is going to be that pec major and minor, as well as our clavipectoral fascia. And then our posterior is going to be the lats, teres major, and subscapularis. Okay, upper arm blood supply. So how I remember this is for subclavian branches are vitamin C and D. So VIT, so that stands for vertebral. Then the next branch that comes off is internal thoracic. Then the T is thyrocervical trunk. C would be our costocervical, and then the next branch coming off is dorsal scapular artery. After my subclavian, then I've got my axillary. And so the branches off of that, how I can remember it is 60s, teens, love, sex, and pot. So superior thoracic is the first one that comes off, and that stands for 60s. Thoracoacromial artery is our next one. Lateral thoracic comes off next, and then subscapular artery is our next one. Since in our mnemonic we've got sex comes with STDs. So off of subscapular artery, we've got scapular circumflex artery and thoracodorsal artery, so STD. And then our last one, our and pot, would be anterior and posterior humeral circumflex arteries. So make sure you know the order of which ones come off, because if you're looking in lab, for instance, you need to make sure that you know like what goes to what. That's the most important. So like, for example, thoracodorsal, make sure it's going to latissimus dorsi, but it can help you sort of get oriented, and also it's good to know what comes next. Here is our brachial plexus. So this is how I would approach the brachial plexus. Make sure that you can draw the brachial plexus over and over again. And then after that, if you can draw it in your sleep, then the next step would be that you need to be able to add in, okay, what muscles does this nerve innervate? And all of these muscles are actually written under the nerve themselves. So musculocutaneous, for example, it says biceps brachialis and coracobrachialis. So it's going to be our elbow flexors. So be able to say that. But of course, there's some of them like long thoracic. Okay, that's serratus anterior. Be able to know what those muscles are. After you know that, be able to like talk about, okay, what action do they do? And then be able to answer, okay, what is the blood supply that also corresponds to this? So like serratus anterior, even though it's a long thoracic nerve, it's a lateral thoracic artery. Once you can do this, make sure you can go into lab and be able to see those cords and also the branches. Okay, veins of the arm. Veins are typically important, but there's two main ones that you do need to know. There's cephalic vein and basilic vein. Now, make sure, don't just think, okay, people told me lymph nodes and veins aren't important. For the main part, they're not, but they're definitely going to ask you some questions about the main ones. And this is definitely something that you need to know. So my cephalic vein is more on the lateral aspect of the forearm arm into my dorsal hand, and it's going to drain into my axillary vein. So make sure that you know which one it drains into. My basilic vein, it's more on the medial portion, and it's draining into the brachial vein. So if you can't remember, okay, what do they drain into? Brachial and basilic both start with a B. Okay, here's my brachium. So the way I like to think about it is I like to compartmentalize things. And so what in the world does that mean? So the muscles of a compartment, they typically will all have the same blood supply, nerve supply in action. So if I am looking at the anterior brachium, the only muscles that are there are biceps brachii, coracobrachialis, and brachialis. All of these have the same blood supply. They're all brachial artery. They're all innervated by the musculocutaneous nerve, and they all flex the elbow and shoulder. On the posterior side, we've got our triceps brachii making up the posterior compartment. Its blood supply is deep brachial artery, radial nerve, and extends the elbow. So instead of having to learn what blood supply and innervation goes with every single muscle, if you can just know, okay, I know what the muscles are in the anterior compartment, and I can maybe like on my scrap piece of paper during the exam, draw this out and think, okay, I know that the anterior compartment is the brachial artery, then you're going to know the blood supply for those muscles. And that makes it a lot easier to learn this material. The antebrachium, that would be my forearm. Now, it's got a whole lot more muscles. So we've got an anterior and posterior compartment, but we also have a deep compartment for those as well. So my anterior compartment, blood supply is the ulnar artery, and the nerve is the median nerve, and it flexes the wrist. So the superficial muscles are pars-vel muscles. And you can actually, like, they go in that order. And if you put your hand over your, if you put your left hand, your first four fingers, digits 2 through 5, over your forearm, that would be the order that they would go into. So we have pronator teres, pars, flexor carpi radialis, that would be our fel, palmaris longus, that would be pars, and then our last fel, flexor carpi ulnaris, and that's the order that they go in. Now remember, radialis is on the thumb side. The deep anterior muscles are flexor digitorum superficialis, flexor digitorum profundus, flexor pollicis longus, and pronator teres. And the first three, not pronator teres, but they pass under that flexor reticulum. So if that gets pressed down on by our flexor reticulum due to inflammation, then that would be our carpal tunnel syndrome. the blood and nerve supply are anterior interosseous, nerve and artery. And the action is flexing the fingers. Okay, our extensor digitorum, digiti minimi, and extensor carpi ulnaris, they are in the deep posterior side. The posterior superficial muscles are brachioradialis, extensor carpi radialis longus, and extensor carpi radialis brevis. And the ones with 2 stars, that's actually the radial nerve instead of deep radial. So brachioradialis and extensor carpi radialis longus, it's actually attaching above our forearm to our arm, and so that's why it's getting the radial nerve. Supinator, abductor pollicis longus, extensor pollicis brevis, extensor pollicis longus, and extensor indices. Those are also in the deep compartment, and the supinator is innervated by my deep radial nerve. So it really helps with these to be able to know what compartments they go into. So it wasn't as important maybe with the brachium because there's only a few muscles, but with these, if you know what compartment they go into, it makes it so much easier to know what the blood supply is and what the nerve is. Okay, so it's also very important to know about the dermatomes and the sensory innervation. I know it's annoying, it's a lot to know, but let's say this patient doesn't have, they can't feel, let's say they're pinky. You know, as a doctor, you need to know, okay, what nerve is actually affected. And so that's why it's really important to know these. Also, it just keeps coming up over and over again. You're going to have to know it for OPP, you're going to have to know it for EPC, and definitely next year. So just make sure that you can start learning this now. Also, it's going to be in some question stems as well. Okay, so the collateral circulation around the elbow. So above the elbow on our medial side, we've got our superior and inferior ulnar collateral arteries. On the lateral side, that's our thumb side, we've got our radial and middle collateral arteries from the deep brachial. Below the elbow, on that medial side, we've got our anterior and posterior ulnar recurrent arteries, and the lateral side, we've got our radial recurrent. In the cubital fossa, that's inside your elbow joint area, that's called, the boundaries are going to be pronator teres, brachioradialis, brachialis, and supinator. The contents are going to be biceps brachii tendon, brachial artery, and then median nerve. And so in order of this is TAN. So it's the tendon, artery, and then nerve. So the ligaments of the elbow. So the elbow joint is reinforced by that radial, ulnar, and collateral ligaments. But also there's going to be the annular ligament. So that's really important to know. It encircles the head of the radius, and a clinical note is the nursemaid's elbow is where a child's elbow slips out of that ligament. So just make sure you know where that is. Maybe you can find that maybe on a model, for instance. That's important to know what ligament that is. The anatomical snuff box. So if you make the snuff box pattern where you extend your thumb, you can see the tendons pop out. And so this is a brevis sandwich. So what's that mean? We've got longus on the outside, like that's our bread, and then brevis is our peanut butter, for instance, if we're having a peanut butter sandwich. But in this case, it's a brevis sandwich. So we've got extensor pollicis longus, that's our top piece of bread. Then we have extensor pollicis brevis, that is our middle piece of bread. And then we have our abductor pollicis longus. The styloid bone is at the base, and this is really important because it can be broken with a Fuchs injury. So what in the world does that mean? That's fallen on an outstretched hand. The contents inside is the radial artery. So know if they tag something in there for the practical that and it's looks like an artery, it's our radial artery. Bones of the wrist. I know that people have different mnemonics of remembering it, but this is the one that I learned. Scared lovers try positions that they can't handle. So, for instance, if there is a picture of an x-ray, you can see those bones of the wrist. Make sure that you know which one is which. And in the picture, I drew arrows so you know which one goes to what. And so, scared starts with our scaphoid, and we can find that scaphoid bone because that's at the bottom of our snuff box like we just talked about. And so going around to the lateral side, we've got scaphoid, lunate, triquetrum, and pisiform, and then we start at the top again, and so we have trapezium, trapezoid, capitate, and hamate. Okay, palmar branches, the palmar muscles of the hand. So these are hard to a lot of people, but don't worry, they're not too bad. So a lot of these muscles are brevis muscles, and brevis is sort of like a baby muscle. I just think of baby every time I hear brevis. In the hand, they're just tiny little muscles. They attach just in the hand. They don't go to the forearm. The lumbricals, they're going to attach to that flexor digitorum profundus that we talked about. And then our innervation is going to be 1/2 med loaf. All others are ulnar nerve. So I put med in there because I need to remember that that is the median nerve opposed to the ulnar nerve. And also I think it sounds like a meatloaf. So 1/2, so half of the lumbrical, so that's digits 1 and 2, that's the L. The O is my opponent's pollicis. The A is abductor pollicis brevis, and then the F is flexor pollicis brevis. And you can see that right here in the colors. So if I'm looking at the hand and I'm looking at my thenar and hypothenar muscles, in the yellow on the outside of my hand, I know it's bringing it apart, so that's going to be my abductors. Pollicis means thumb, and of course it's a brevis. Digiti minimi is just the mini digit, which would be my pinky. And so those outer ones bring my hands apart, abducting. Right inside of that, I've got my flexors. So flexor digiti minimi, brevis, and then flexor pollicis brevis. Under my flexor pollicis brevis and abductor pollicis brevis, it's deep to it, is going to be my opponent's pollicis, and that allows my thumb to be able to touch my pinky finger and all my other fingers. We need to have that opponent's function so that we are able to write and grip things. Adductor pollicis, it makes a 7 shape. It's really deep. You have to get rid of the other muscles, and that's my adductor pollicis. So there's 2 abductors, pollicis brevis and longus, but my adductor is just one, and it's the pollicis. So make sure you know that. Some people get confused. My interosseous muscles, on my dorsal side, I've got my dabs, as I like to say, and then on the palmar side, I have my pads. So what does this mean? So I got my dabs and my pads. So dorsal side, they're going to abduct, and on the palmar side, those interosseous muscles adduct. So the blood supply to the hand, the superficial palmar arch, the major supply is the ulnar artery, and the deep palmar arch major supply is the radial artery. However, they anastomose and they get a little bit of both, but it's important to know what the major supply is. Look again at dermatomes of the hand as well as the sensory innervation. That's very important to know. Joints of the hand. So going in between each one, they're named for their articulations. Radiocarpal, radioulnar, ulnocarpal, it's named right there, radius carpal, that means wrist. So radiocarpal between the radius and the carpals. Midcarpal between the carpal bones. All those bones that we named. Carpometacarpal between the carpals and the metacarpals. Ligaments. So we've got collateral ligaments, our MCP joint, that is abducts and adducts, those collateral ligaments, and then at the IP joints, they flex and extend. The palmar ligaments prevent hyperextension, and then our deep transverse metacarpal ligaments hold the heads of the metacarpals together. Here I thought was a really nice review slide showing wrist drop, hand up benediction, and claw hand, and knowing what the motor deficits would be. So I just thought that that would be a really nice summary of all of the branches of the nerves. Please let me know if you have any questions, and it's been my pleasure.